Hi, good morning. I'm Craig Lammert. I'm a hepatologist at Indiana University. I'm also the executive director for the Autoimmune Hepatitis Association. I want to welcome you and thank you for joining for a talk entitled The Latest Autoimmune Hepatitis Research. Before we get started, I just want to say thank you for the organizers of this digital online meeting, but also thank you for our programming conference committee members that also pick the topics directed just at patients and their families. So again, thank you. Let's get started. So when I was asked to do this talk, it was a little bit overwhelming as there's been plenty of autoimmune hepatitis research over the course of the past few years. I took an approach when I developed this talk to really drive to what I thought were important studies that may highlight some important pieces of this disease, maybe about how it works, but also theoretically some things that patients and their doctors should be doing in the clinic as well. But first, let me start with the Dunning-Kruger effect. Now, this is best explained by a graph here. Now, you may have seen this throughout the coronavirus pandemic, but this is actually an approach to look at a complex issue. As you see on this graph, the confidence starts at low and goes to high on the y-axis. Also, then knowledge starting at low to high on the x-axis. Now, it turns out this concept is really important in any problem, especially in the complex issue of rare disease like autoimmune hepatitis. And the idea behind the Dunning-Kruger effect is really it's a problem with metacognition, or the ability to analyze one's thoughts on performance. And I think we all fall victim to this. And at the onset of any complex problem, when we see the initial issue, we're taken back a little bit about a really big problem. Now, you can actually think about this with your own disease course with autoimmune hepatitis, but also as a physician, I think about when I first learned about this disease, or even as a researcher, trying to unravel some of the problems with autoimmune hepatitis. But very quickly, someone suffering from this effect may have tremendous confidence in their understanding, even when knowledge is really low. Now, a good example of this for AIH is the discovery of AIH, but also the treatment with steroids. We had this disease whip. Now, this was 40 plus years ago. Yet this confidence can be a curse, as it can lead to incorrect conclusions and possibly errors. Actually start to realize that maybe it's not so easy. And in fact, this disease could be a little bit tricky, but it can lead to these incorrect conclusions. But also the inability to examine oneself will prevent us from realizing these errors as well. And as we get beaten down by the challenges, we start to give up and realize, hey, this is way too hard. In fact, this may be, along with this disease, the fatigue or the side effects you have from this. Doctors can't discern what's going on, what's driving this problem. They can't make it better. Yet over time, we start to realize that there's new data. In fact, new experience. And some of these things start to come together and become a little bit more clear. But the clearness is not with understanding, but the realization that it's hard and or complex. I wanted to start here because I think that we've seen some changes in the medical and research AIH community that follow this curve actually quite nicely. It's been a shift towards what we know about AIH for the diagnosis, the treatment, the management, that in fact it is complicated, and hopefully more scientific work as well as patient input will improve our understanding of this disease compared to really the past 40 or 50 years. And in fact, maybe after all, doctors did or currently don't always know best, and I would lump myself into that group as well. Furthermore, we have a variety of people watching us today that maybe at different points on their course of disease understanding or disease course itself. I want to see if we can actually move you to a more, trust me, this is complicated perspective. As once here, you may realize that there are no simple decisions made in AIH, and patients often have complex issues that require complex answers and approaches. Part of realizing AIH is complicated is understanding the research that's being done in this rare disease. But I want to tell you, research is also hard. And in fact, it takes a dedicated investigator or clinician or someone in a wet science lab to come up with a question and then determine an approach or a scientific study to how to answer that question. Now, in rare disease, as you could expect, there's not a lot of patients. So in fact, sometimes this can be a major hurdle, sometimes financially, where there's no money to conduct research. But once the research is done, which again can take months to years, That data is then compiled in a paper with multiple authors. Now that paper must be verified. And what has happened is it's submitted to a journal. Now there are hundreds of academic journals, but just to give you a snapshot of what that would look like, when you send it to a journal, it goes to the editor. That editor then takes that information or manuscript and sends it to a list of expert reviewers, which may be very different depending on what the paper is about and or what the journal focuses on. Now, once those individuals look at the paper, they decide about the scientific rigor, the outcomes, the understanding of the data, and it goes through a few different pipelines. Now, it may be not of high enough quality, and in fact, doesn't answer an important question. Therefore, the editors may reject that article and go back to the submitting author. However, there may be some interest in things that they want to ask further questions. They actually request a revision for that author to submit again for possible publication. Now, very infrequently it happens that peer reviewers actually think these articles are excellent at the first go around and lead to publication right off the bat. But where does it go after it's decided to be published? How do we use that data? So there are a few questions that come up and really thinking about how the new data or the new science gets implemented into clinical practice. And there's a few considerations that I want you to think about. So one, is that data, is that publication freely available? Now, again, there's a paywall in a number of different journals. I'm fortunate to be at a large academic center. Often my library has access to a number of different journals, so it's very easy for me to get that information. But maybe not so for everyone else involved, including other doctors at smaller centers, but also important patients. The other question that you must ask when you read these papers is it a high quality study? What are the impact of these findings? Can you actually generalize from that study population or that group to other populations that you may be treating in the clinic? Also, is the science easy to read and is it understandable? Now, depending on the type of data it is, the type of research, it may be very hard to understand that. So in fact, you depend on some of these expert reviewers to make sure that the rigor of the study itself holds true. Finally, patient interpretation. We already identified that getting information to patients is a challenge, particularly in the academic level, but can we rely on our clinicians and doctors to translate this material to patients, also keep up on the literature, but also change their practice to potentially benefit patients in the future? Now, AIH yearly publications continues to climb, and this is really important. So as you can see, back in the 1960s, there was not much interest in AIH, and this was actually when this disease was probably more codified via the chronic active hepatitis terminology. But over time, there's been interest in growing over time for a number of publications that come to be published in academic journals. As you can see, last year, there were 654 individual papers published on autoimmune hepatitis, and this year we're actually doing not so bad as well with 349. Now, many of these, unfortunately, are review articles, which doesn't really consolidate any new data or science, but again, it's still driving the interest in AIH for patients. Now, I want to give you a comparison. Now, fatty liver disease or non-alcoholic steatohepatitis, we see publications rise there as well. Now, compare those numbers that I showed you for AIH to what was published last year for NASH. Definitely a lot more interest, but specifically NASH is also a more common disease. But I think the point of showing this is AIH has a lot of room to grow. Now, for the first publication I want to show you, this is a little bit of a technical and actually a wet science type of experiment, but I think it shows some really important pieces about how the immune system work together. The ultimate take-home point of this article will not be about any future treatments, but in fact, that we are starting to better understand the way that these cells communicate. By understanding how they communicate, we actually may find that we find better treatment strategies that are a little bit more targeted for AIH. Now, part of the study and the background knowledge, as you must know, is these things called CD4 positive T cells. We'll also call them T lymphocytes. They play an incredibly important role in what we call the pathogenesis of AIH, or what is the piece of the immune system that's causing liver cell damage in this disease. Now, there are a few reasons that we know T cells are really important. First things first, there have been genetic studies that have identified what's called the HLA-DRB1. This is a protein that's on another cell that connects to T cell receptors. So in fact, seeing that from prior genetic studies, we know the T cells, there's something wrong with them in AIH patients. We also then, when we look at a biopsy of AIH patients and we stain it accordingly under the microscope, we actually see these lymphocytes within the liver cells causing problems. Another cell that's important in AIH is the B cell. And there's a few reasons that we know that as well. Specifically, you look at the blood with AIH patients, we see a very high level of increased gamma globulins, or the IgG levels. Now these proteins are distributed and made by B cells. We also then, when we look at the liver biopsies of AIH patients, you can also see plasma cells sitting next to these T cells in ongoing inflammation. Now, B cells have actually been studied quite routinely in AIH. It's because the B cells actually make antibodies, and it's very easy to measure antibody levels in peripheral blood versus looking at the liver for T cells, which are actually seen to be more localized to the liver and cause the inflammation. Now, these cells likely work together to cause the problems of what we see in the patients with autoimmune hepatitis. And in fact, we know this because the CD4 T cells can actually recognize certain material or protein that is then also identified in the autoantibodies formed by the B cells. So there is two compartments involved and show a strong response to certain proteins that may be driving this immune reaction. Let's talk about this just a little bit more. Here on the left, we see the T cells. Now, some of them have these blue centers or nucleuses. Some of them have red centers, and it actually identifies cells that have been activated and targeting the liver and infiltrating these liver cells here derived as hepatocytes. With that destruction, we see the liver cells break open. These actually can drive other inflammatory cascades, but also potentially fibrosis. But really the important piece here is the B cells work as a co-activating signal for CD4 T cells that then drive this inflammation as well. This then leads to the change in what we see here is a beautiful piece of liver where we see plates of hepatocytes in these long, slender pink rows, in between them with red blood cells, as the blood is percolating from what we call the portal vein as it transgresses through the liver cells to return to the central vein and then back to the heart. Now in AIH, this looks very different. With activated CD4 T cells and the B cell activation, that liver biopsy no longer looks pristine. As you can see, numerous amounts of nuclei that have been associated with the T cells, but also in here as well, you'll see B cells that are serving as a co-activating signal. Now in this study, there were a few key findings, and this was actually an assessment of 60 AIH patients compared to other control groups. And ultimately, the goal of the study was to better understand how these cells are interacting with each other. Now, there were a few key findings I want to make you aware of. The T cell receptor, which is actually on the outside of the T cell, and the way that it communicates with its environment, there were certain genetic changes that were there, not only in the T cells in the liver, but also in T cells in the peripheral blood. And this was interesting to the authors. In fact, these pockets or clones of T cells were probably driving a lot of the inflammation and were primed to do so because of this variable region was very similar across a number of these patients. Interestingly, these were not associated with the classic gene risk factors that we've known about AIH before. We also saw that these gene rearrangements were there before, but also after treatment with immunosuppression, which is concerning because in patients that we withdraw therapy from, that genetic change can actually spawn the reactivation of autoimmune hepatitis. Interestingly is that the B cells themselves didn't seem to have any of these different shifts in genetic material. And in fact, there was no signature in the peripheral cells, but or in the B cells that were in the liver too, which the authors thought was really important. And in fact, these need to be driving from some other signal for inflammation, but also it's unclear how important these are in driving the T cell activation in the liver itself, which raised a number of questions to the authors. How important is that we pick agents that impact B cells? On that note, there was a published study this past 2 years looking at Rituximab, which is a biologic agent that is targeting the clearance of B cells. By administering Rituximab, this actually binds to B cells and takes them out of circulation, slowly removing B cells from the periphery. and has actually been looked at case reports historically up to this point of trying to understand if rituximab is a good salvage therapy for patients that are hard to treat. Now, in this study, the authors, who were European, collected 22 patients that had used rituximab to treat their hard-to-control AIH. Now, specifically, hard to treat was defined variably, but these were patients that did not respond to what we call first-line therapies, like plain old prednisone or azathioprine. Here we see the 22 patients and their different medication regimens to that date of using rituximab. I actually found this a little bit interesting as it also highlights different approaches of different doctors across different academic centers. As I see here, you see a large percentage of patients that have actually only tried prednisolone or azathioprine and not utilized any other second or third line agents such as Cellcept or tacrolimus, which is also Prograf. Now, in these patients that were treated with rituximab, the authors actually see ALT reduced significantly after infusion, starting at 1 month and lower after 3, 6, 12, and 24 months. We also see one of the key findings in these patients was about half the individuals shown on the right were able to reduce or go off their prednisone. Other things the authors saw in this study was that rituximab was generally well tolerated by patients and actually didn't result in any bad outcomes. So again, further consolidating this as a way to treat patients that don't respond to the classic first-line therapies. Now, the very last complex study I want to highlight with you is looking at what's called regulatory T cells. These are a little bit different than the active T cells I showed you that cause all the problems with autoimmune hepatitis. These T cells are also in the liver and periphery, but these T cells actually do something a little bit different. They are the brake pumpers of this disease. And in fact, they work to slow the overreactive nature of CD4 T cells. One of the challenges with treatment with first-line agents, including prednisone, is we think that those medications lower both the CD4 T cells, but also the regulatory T cells. And in fact, some believe that the regulatory T cells are suppressed even further. So because of that, when you remove therapy, when the immune system comes back on 100%, the Treg cells are lacking, and in fact, you increase this risk of recurrent disease once therapy is stopped. So in this study, which included an animal model of autoimmune hepatitis, the investigators used a certain type of interleukin-2, shown here by these blue crosses. Interleukin-2 actually activates T regulatory cells, but the authors actually looked at a different type of interleukin-2, one that was a little bit lower dose. One of the reasons was because when you give interleukin-2 to patients, it actually acts on a number of different compartments of the immune system. And the authors just wanted to target T regulatory cells. What they saw was IL-2 in this form actually was able to restore natural balance to an autoimmune hepatitis mouse model. Ultimately, what they identified was that these Treg cells and CD4 T cells imbalance needs to be restored. And in fact, IL-2 may be able to do this. And this actually could be part of the future of therapy for autoimmune hepatitis patients. Interestingly, IL-2 therapies have been looked at other autoimmune conditions as well, such as lupus and lupus nephritis. But the authors identified that this type of interleukin-2 needs to be selective and only target this certain type of regulatory T cell. I think IL-2 based therapies and Tregs specifically too could be the future of AIH treatment. And I think the upcoming years will help to clarify that even more. Shifting gears, let's move away from the wet bench and the immune system, and let's look at some population-based studies with autoimmune hepatitis. And really a question we've seen in the literature in the past few years, is the incidence of AIH increasing? And in fact, in Sweden, we've actually seen a stable incidence over the past 13 years that was actually just recently published. However, in Denmark and in the Netherlands, we've seen an increase in incidence or the rate of autoimmune hepatitis as well. Now, the authors of this study are out of New Zealand and actually are in an area called Canterbury. Canterbury has actually been utilized to look at AIH before. However, they wanted to reassess this population to see, is the slope of AIH diagnosis even higher than it was over 10 years ago? Now, what the authors found was that AIH, here identified by the blue line, increased considerably from 2008 to 2016. Now, comparing this to PBC and PSC, other autoimmune bile duct diseases remained actually quite flat. Now, the authors didn't know exactly what was going on first. In understanding why this happened, they couldn't determine. They thought maybe there could be some diagnostic scrutiny, meaning that we were just looking for AIH more, but they thought probably not, because in fact, they're also looking for PBC and PSC as well, yet these did not increase over the time course that they followed. There was an inflection point in incidence. We see this in the year 2011. The authors considered what had been going on in this community then and realized that there was ongoing earthquakes that really wrecked a lot of the city, but caused a lot of deaths and a lot of mental anguish. Other studies have looked at this and actually saw an increase in mental health problems that were going on from that time course as well. So this led the authors to conclude that mental health and other stressors in life could be a really important factor on why we've seen some increase in autoimmune hepatitis over the course of the past 10 years or so. Now, the next study is looking at bone health. Now, this may be something you've never even discussed with your doctor, but something I bring up routinely in patients in my clinic, merely because there was an earlier study from these authors that looked at 211 AIH patients. And we see osteoporosis or significant bone loss in these patients of about 20% among those individuals more than 50 years old. Now, this is a really important number. In fact, what they identified were patients that were on prolonged steroids for more than 90 months, individuals that were a little bit lighter with BMIs less than 23, and those that had increased stiffness on their fiber scans, or that non-invasive way of looking at liver stiffness, were at higher risk of having significant bone loss. Now, the classic way we measure bone density is using the DEXA scan, but the authors make a really important point. Bone mineral density measured by DEXA scan is not all that relates to fracture risk in patients with AIH. In fact, they make a point of saying that 50% of fragile bone fractures, those patients have densities well above that of osteoporosis. So there must be something more to it. And the way that we measure this in the clinic is using the DEXA scan. But DEXA scan has limits because it can't differentiate between poor mineralization of the bone, but ultimately just bone loss itself. Furthermore, when we look at the spine in these studies, degenerative changes that many of us get over time can look like false high density because of the inflammation that also may drive some bone formation there as well. Ultimately, the authors made a really important point that really this 3D bone structure, which actually has been shown in some other diseases to be important to gauge fracture risk, hadn't been done in AIH. So these authors used high resolution bone architecture scanning in about 50 patients and 30 controls. And these are what they noted. Now, there are two different types of bone. There's trabecular bone, which is in the middle of the bone, and then there is a layer on the outside called cortical bone. What they noted was the trabecular bone was stable in AIH, but there were some thinness areas specifically related to steroid use, they thought. But we actually saw more cortical bone loss than would have been expected in patients of that specific age, but also BMIs. So cortical bone loss was more significant in AIH patients. Now, this pattern of loss has been seen other places, but the reassuring thing is there's actually certain therapies that actually may target cortical bone loss as opposed to other forms of bone loss as well. The authors thought that this pattern was also similar to what had been seen in other autoimmune diseases and potentially could be related to ongoing peripheral inflammation. Once again, they saw decreased thickness in this layer of bone or cortical bone, and it was associated with age, but not fibrosis and not the disease duration or other markers of inflammation seen in autoimmune hepatitis. In fact, again, this was more accelerated in AIH, even though typically cortical bone loss comes after 65 in most patients. And a very last point with AIH and bone density, if you follow the guidelines, we should still be using DEXA scan to measure bone density at least every 2 to 3 years in patients that are already at risk. However, in individuals that are already of elevated age, when they're diagnosed with AIH, it's often a good time to go ahead and start doing the bone density screening. So now we're going to dip our toe into the novel coronavirus and specifically the current pandemic. Now, autoimmune hepatitis after vaccination is a topic of big discussion. Specifically now that we've all been asked to get our vaccination, the question that comes up is, are individuals at higher risk of autoimmune hepatitis after this vaccine? And in fact, there's only 2 instances in the literature currently published of someone developing autoimmune hepatitis after vaccination. Now, data exists from cellular models, not in patients, but where the formation of antibodies towards the spike protein that had been coming from a vaccination actually can then target some human tissue proteins. And the authors of this study, which was just a letter to the editor, indicated their pregnant patient that left the hospital, discharged on a blood pressure medication, and then had her first dose of Pfizer a week later. And what they saw was when she returned, because she was now yellow a few weeks later, her liver tests, specifically ALT and AST, were well above 20 to 30 times the upper limit normal. However, with a biopsy, which was done just a few days later and shown here, showed marked inflammatory activity consistent with autoimmune hepatitis. Also, they treated her with prednisone and saw a very prompt improvement and resolution of her liver tests in the months following. Now, there's been some speculation with this study, in fact, that this patient was pregnant. I will also comment that I've diagnosed autoimmune hepatitis either during pregnancy or shortly thereafter in a handful of AIH patients, but there's been at least one other case similar to this, however, an 80-year-old woman that has happened after vaccination for novel coronavirus. However, it's also worth mentioning that there's actually been diagnosis of AIH after COVID-19 published in the literature too. Again, we don't understand why, but we see patients with severe COVID-19 infections to see marked elevation in liver tests and ongoing inflammation. There are some in the field that think that this may unroof autoimmunity or at least get the inflammation started, which then may spiral out of control. Again, only a handful of these cases have been reported in the literature. So let's talk about immunosuppressed patients. How do they respond to the vaccine when they are vaccinated? And first things first, I will say from an organizational perspective, we think you should get the vaccine unless there are some other extenuating circumstances that are preventing you. But one of the biggest questions after vaccine is, does that patient develop appropriate antibodies? And it's those antibodies which are made by those B cells that are protective, we think, from the novel coronavirus. Now, there's been rapid production of data to highlight how patients are responding. And so from a few months ago, patients that had dose 1 and dose 2 of their either Moderna or Pfizer vaccines among patients that were transplant patients and on immunosuppressants, what they noticed was 15% of patients after the first dose respond with some level of antibody formation. However, among those that don't respond after dose 1, there were about 39% that finally did after the second dose. More importantly is about half of these individuals that are on immunosuppression did not respond at all. This led to a follow-up study that looked at 30 transplant patients and really to see what their response was in patients that had no antibody production after the second dose. And could those patients, in fact, be rescued by giving them a third dose of vaccine? So what they saw in the study was after the third dose, individuals that had previously low levels, all of them had increased spike antibody protein levels. Those individuals that had no detectable levels after their prior 2 doses, a third of them actually were able to be rescued. Now, the important finding of the study is there are still people that even after a third dose or a booster dose did not have a response that we would expect with antibodies targeting the spike protein on coronavirus. The authors also looked at how tolerable a third dose is. In fact, they saw some mild to moderate reactions. Specifically, fatigue was the most common in about 50% of this group. Changing gears again, we want to look at the genetic background and other environmental contributions as they work together to cause this disease, a really important conceptual idea, as we cannot change our genetics, but we can change our environment. And in fact, as has been identified in other talks, there are drugs such as minocycline and nitrofurantoin that have been linked with autoimmune hepatitis, but there's a whole list of other things that may be problematic and could contribute to the development of autoimmune hepatitis. This actually is an area of our expertise and interest here at Indiana University as well. Ultimately, can we identify things that we expose ourselves to that either may lower our chance of getting autoimmune hepatitis or actually could be a modifiable factor as we treat AIH patients going forward? So setting the stage of how environment can impact us as humans, there was an interesting coffee study of all things that was published about 6 years ago in the New England Journal of Medicine. In fact, in this study, there were over 400,000 individuals in what was called an AARP study. Ultimately, what was noticed was those individuals that drank coffee saw significant reduction in overall cause of mortality. So the risk of death went down. In fact, when you look at the genders, women actually had a higher risk reduction of 15%, but men also had 10% risk reduction. But ultimately, this held true for a lot of different diseases and causes of death, but not for cancer. Now, this finding of coffee has been known about in liver disease for a number of years. And in fact, about 30 years ago out of California, a study was done in patients that were drinkers and had liver-related disease secondary to alcohol. And those individuals that not only drank alcohol, but also drank coffee seemed to do better. They had lower liver tests, they had less fibrosis. So in fact, could coffee be an important strategy to control liver fibrosis? We looked at coffee use in AIH patients this past year at Indiana University as a part of the GRACE study. And interestingly, what we found was AIH patients as a whole drank less coffee than healthy controls. In fact, almost a quarter of our patients that participated never drank coffee, compared to a very low 15% of controls. Ultimately, we saw current drinking was also lower compared to controls, but also among those patients that were ever coffee drinkers, meaning that you still drink, they actually drank less with fewer lifetime cups per month, and they spent less percentage of their life drinking coffee. Another important finding from the study was, in fact, when we looked at liver transplants patients that required that as a way to treat their AIH, we didn't see any difference between coffee in those patients and those that had not had transplant. So I don't think there's a strong signal to prevent fibrosis progression or liver disease damage beyond with coffee use. But again, I think we may also be underpowered to see that as well. Beyond coffee, there's a lot of other environmental things that we're exposed to. And this was the focus of our next study that looked at things outside of coffee and how this relates to patients with AIH and those that don't have AIH. And here at IU with our GRACE study, we had 350 AIH cases, and we compared those to responses from 563 healthy controls. And some really important phenomena came out of this. And in fact, we saw an increase of AIH risk with patients that have had urinary tract infections ever in their life, or recurrent urinary tract infections, which means more than one per year. We saw an increase in AIH among those patients that had used oral contraceptives, as well as those individuals that had less pregnancies. Also, current smoking for some reason also increased the risk, but not a history of smoking. Other illnesses were also associated with AIH. As you would expect, many of our AIH patients had other autoimmune diseases, more so than healthy controls. But also our AIH patients had more gallstones, reflux, or GERD, but they had also seen more disease such as mumps or rheumatic fever. We also asked about vaccine history. And we also saw that our AIH patients were more likely to be vaccinated against chickenpox, measles, mumps, rubella, pertussis, and pneumococcus. Now, a really important thing here is that this is purely an association study. This does not highlight an absolute cause of AIH. However, better understanding the environment going forward is an important treatment strategy as we consider other therapies that actually may modify this disease. And finally, let me leave you with some action items and things that you can take home. I want you to remember AIH is complicated. So no matter where you are in this disease and how challenging the symptoms may be, it's complicated to diagnose. It's complicated to treat. It's even complicated to research this disease as well. But I want to reassure you, there has been progress, and we continue to do so. And using organizations like the AIHA, as well as investigators, to study this disease better, to learning more about the overall care of AIH patients. We know there are different parts of the immune system that are involved in this disease. And in fact, each one of these compartments, T cells, T regulatory cells, and B cells, all represent certain areas that can be targeted with specific immunotherapies. And it's a really exciting time as we are now seeing a new form of therapies that may be coming that would be in the realm of possibly T regulatory cells, also interleukin or other molecules that stimulate Treg cells. Bone health is critically important. In fact, getting your DEXA scan at least every 2 to 3 years is an important strategy, and I would ask you to even remind your treating doctor about this. At diagnosis, I do DEXA scans in all my patients, but also I ensure that they are getting adequate vitamin D supplementation, as low vitamin D levels have also been associated with worse outcomes in AIH patients. Getting a vitamin D level every year would be another part of the strategy. Also, SARS-CoV-2 or the novel coronavirus vaccination we think is safe. But in fact, the response after vaccination in patients that are immunosuppressed may be a challenge. And right now, we don't know whether to check these levels or not, or how we'll approach it with booster therapies. But I will ask, if you want to keep an eye on this, follow us on the AIHA, on our Facebook page, as well as our website, as we will give you the latest and greatest research as it comes out in this really important topic. And finally, thank you for joining us today. Staying up to date with research is, I think, an important thing. Now, this may be sometimes challenging for patients to understand, but I think this is important for all your doctors to also be considering as they consider how they treat AIH patients and how their practice may change with incoming data. But well-informed patients and doctors will have the best chance of optimizing the treatment of AIH. Thank you for joining me today.